Hi, welcome back. If you're looking at our videos again, and welcome if this is the first time. I'm Dr. Martin Rutherford. I am a chiropractor, 36 years. Currently, my practice is primarily a practice that involves functional medicine. I am a certified functional medicine practitioner, and I practice along with Dr. Randall Gates.
I am a chiropractor as well as a board-certified chiropractic neurologist.
And so together with our certifications, it turns out that we had a very good background for developing a chronic pain practice, in that we were able to, as chiropractors, understand a lot about the musculoskeletal system and the nervous system. But with Dr. Gates's diplomate, he is very well versed in the brain and its function and how to correct it for the most part, without drugs and surgery. We are not medical doctors. And in functional medicine, we look at the rest of the physiology, the other 8 systems of the body, and how that works, and how that contributes to chronic pain, and how to correct it, preferably, right, 80, 85, 90% of the time without any medications. So our practice kind of evolved on its own. And we started out with fibromyalgia. Next thing it kind of morphed into peripheral neuropathy. Next thing it kind of morphed into guts and thyroids and all this stuff on its own. And one of the things we see a lot of is, well, I would say Dr. Gates cut his teeth on dizziness, vertigo, and balance problems. That's migraines. With Dr. Ted Carrick, who is the developer of these neurological procedures, which are, I must tell you, very successful, deceptively simple in their application, not so simple in figuring out which ones to use. But between that and between what we're doing with functional medicine, we've developed a kind of chronic pain practice that has also come to involve a lot of dizziness and vertigo and balance problems. And Meniere's, it seems to be a popular condition that seeks out our office. And our approach, without being promotional here or anything like that, we're just trying to share things with you. Our approach has been, I would say, consistently successful. I would say with a substantial improvement. A lot of these cannot be cured, and we'll share with them why that is. But they can certainly be brought to the point where you're normal most of the time. And when you're off a little bit, you'll know pretty much why, and you can know pretty much either why it happened and or how to control it. Most of the time without drugs, at least in our experience and our understanding of it. So to set the stage, I do the consultations here. I'm involved in consultations and exams and so on and so forth. Dr. Gates does virtually 99% of all the treatment. And so we're kind of a good team that way. My part is in kind of screening patients to determine whether they would be a good candidate for what we're doing. And the things I see is people come in with Meniere's. And most of the people coming with Meniere's have been diagnosed with it. Unlike a lot of other things, people come in, they don't know whether they have fibromyalgia, they don't know whether they have peripheral neuropathy, they don't know whether they have chronic fatigue or celiac or whatever. But they seem to come in with a diagnosis, and you can talk about that in a little bit. So the issue doesn't seem to be, as in most of our other cases, getting a proper diagnosis. The issue seems to be, I've got this, I've been told, I'm using the medications, I've been told basically, that's it, I have to live with this. It's not getting any better, the medications are giving me other side effects, or I still want to take the medication, or I'm getting worse. Or other things are starting to happen that are adjacent to it, that they're not connecting at all. And they might come in with those things, which we'll talk about, and then have Meniere. So that's our world. Okay, that's my world when the patient comes in. And then to tease all of that out and determine whether we can reach that patient's goals, which if you're watching this, you may have the same goals as those patients, which is, I don't want to have this anymore, or I want it to be under control, I want it to be better, I want to get off the drugs, or those are the ones that I kind of have to sit there and determine, okay, I start a program, I'm going to be able to produce these results. So Dr. Gates has put together a nice flow here on addressing this issue, and so I'll be deferring to him and kind of when I interrupt, as I frequently do, it's going to be relative to the fact of what I know patients want to hear, relative to my part of my involvement in these cases, which is a little different than his. So background, I kind of gave the background on how that patient kind of walks in the door and what my experience is, but background on vestibular neuritis. I didn't really hit vestibular neuritis that much but we're going to.
Yes.
Because vestibular neuritis is often the default diagnosis that is given to people who have Meniere's. At least that's what I see.
Sometimes there can be some confusion.
And some people have been told that they have Meniere's who have vestibular neuritis. So that's why we're throwing that in to kind of give you an idea of it. You may be in that category. And it's not a huge category, but we see it, and it's just something that Dr. Yates thought would be prudent to address with those of you watching this. So background on vestibular neuritis and Meniere's.
Okay. So basically from a symptom standpoint, those with Meniere's tend to have vertigo lasting a couple hours that is very severe. We should define vertigo. Vertigo is really the illusion of motion. It's where the room tends to spin around somebody. I had one patient come in who said, they asked me, did the room spin around me or did I spin around the room? She said, that's the dumbest question ever. She's like, how am I supposed to know? And I just thought it was so great. It's the greatest point ever, because when things are spinning, it's really hard to tell what is spinning.
Right.
So anyways, lots of times there's spinning involved, whereas dizziness just more feels like you're out of balance or you're rocking back and forth or you're floating, so on and so forth. So Meniere's disease involves vertigo lasting hours. Lots of times there can be vomiting associated with that. There will be associated ringing in the ear, roaring in the ear. There will be a sense of fullness in the ear, as well as there will be hearing loss through time that can be tracked through certain diagnostic tests, most commonly performed in an ear, nose, and throat doctor's office or an audiologist's office.
And a number of things can cause hearing loss. I've had this.
Oh, yeah.
A number of things cause hearing loss, but when you put it in with the dizziness, the vertigo, the ringing, the fullness, now you're talking Meniere's.
Exactly. And then relative to vestibular neuritis, that commonly involves acute vertigo. The person gets vertigo all of a sudden, and it lasts for days on end, and it's miserable. Of course, it's going to be associated with vomiting. But the interesting part about vestibular neuritis is that there's no ringing of the ear, there's no hearing loss, there's no fullness most commonly. So those are the key differentiating factors. Now, clinical practice is not always textbook. So there are patients with Meniere's who are going to present mainly with vertigo first, or they may present with basically hearing symptoms where they're getting tinnitus and they don't have vertigo, and that makes the differential diagnosis a little more difficult early on. But those are the characteristics. And then relative to the history, I do want to talk about that a little bit.
Okay.
Vestibular neuritis is interesting because commonly it immediately follows a viral illness. Some studies have said 30% of the time, but others have been higher, above 50% of the time, where they'll get sick, they'll have a cold or a flu, and then this vestibular neuritis will follow. And we've actually picked up 3 cases of acute vestibular neuritis through what we term VNG testing, which is where we put goggles on a person and we can see their eyes moving. And if a person's eyes are moving when they're not looking at something, it means they have an inner ear lesion. And it correlated with the upper respiratory tract infection. But that being said, vestibular neuritis was first talked about in 1888 in Geneva, Switzerland, where they were seeing that it occurred in groups. It was actually called epidemic vertigo. And they're thinking that there are certain viruses that are contagious that can cause vertigo amongst groups of people.
I didn't know that. I just got educated.
And then there's actually a similar report.
So I know that now, and I know not to ask if it's spinning, if they're spinning, or one's called. There is actually egocentric vertigo and exocentric.
Yeah, and that's how it's taught in the textbooks, but from a patient perspective.
Yeah.
Like,
so
how am I supposed to know?
So I do ask those questions, and if you notice if you're spinning or the room's spinning, or you're spinning around or the room's spinning around, it's good to tell them. Don't make them think they're crazy if they go, well, I am having spinning around. But yeah, okay, so it's been around for a long time. So vestibular neuritis has been around for a long time.
And really Meniere's has too.
And we see a lot more,
1861.
I think, Meniere's.
The interesting part is
because the medication takes care of the vestibular neuritis.
That's a really good point. So technically, vestibular neuritis
These
is
are
the
questions
second.
I get.
Yeah,
I'm assuming they have the same questions.
Vestibular neuritis is the second most common cause of vertigo. BPPV, which stands for benign paroxysmal positional vertigo, which is where you get little rocks, they dislodge in your inner ear, you move your head,
rocks in your
and you get vertigo for 30 seconds to 60 seconds, and then it goes away. And then you feel dizzy, and you're really freaked out. That's BPPV. Whereas vestibular neuritis is actually the second most common cause of vertigo. But oftentimes, if someone has a really healthy functioning cerebellum, which is the balance center in the brain, they may have vestibular neuritis where they get this vertigo lasting a week, but their brain can compensate typically pretty well. Through time, their vertiginous symptoms will go away. Now, that's not the case for all cases, but that is a flow. So a certain subset gets better, a certain subset has this chronic vertiginous vestibular neuritis. Whereas with Meniere's is a progressive chronic condition affecting the inner ear, and I think that's why we see more of it.
It's not going away or getting control until you get to the true cause.
Yeah, lots of times it's progressive. It can go away in 5 years, but lots of times it gets worse. So that is what I'd say the background information is.
Okay, and that would kind of include the mimics that you wanted to talk about. I mean,
and so
BPPV.
Yeah, BPPV is in the differential. MS, multiple sclerosis, is in the differential because MS can affect the nerve as it goes into the brainstem. Strokes can be in the differential, especially TIAs that may not show up with a CT scan immediately. So there are a number of things like that. Your ear, nose, and throat doctor, your neurologist, your chiropractic neurologist is also thinking of tumors that can grow on the vestibular nerve.
So in an orderly fashion, how would the diagnosis go? I know when patients come in to me, they've always been to the audiologist. Some neurologist to determine whether they have tumors. What would a person who wants to know whether they have vestibular neuritis or Meniere's expect to go through? We talked about the vestibular nystagmography, but it's not my impression that everybody goes through that.
We should probably just outline the ideal flow. Right. The ideal flow would be to see, in the system, they would see.
We're outside of the system, so we're gonna. So this would be the ideal flow that you would probably go through before you would get to somebody like us. If this ideal flow worked, great. If it didn't work, you can look further, as you'll find out here in a little bit.
Yeah. So most commonly, the person will go to their general practitioner, say, "I'm having vertigo, I'm throwing up." There are no other brainstem
like
symptoms.
18 different possibilities.
Exactly. As long as the person doesn't have double vision at that point and they're not slurring their words and not have a facial droop, they'll probably
be a stroke.
Yeah, they'll probably be referred to an ear, nose, and throat doctor. At which point the ENT would take a detailed history to find out if there are only vestibular symptoms or there's a mixture of audio and vestibular symptoms.
Okay. Meaning they don't know what vestibular is.
Vestibular is balance mechanism, basically. It's our inner ear relative to balance, and then audio means basically hearing. So is there a mixture of hearing and balance problems, or just balance? And after a detailed history, the ear, nose, and throat doctor will probably conduct tests where they can really precisely test the hearing of the individual. That's termed audiometry, as well as then VNG testing. It stands for video nystagmography. And you put goggles on a person because if you have really good functioning frontal lobes and if you have an inner ear lesion, you can look at something and your eyes won't move. But if you take that away where you're not able to look at something and we can video record the eyes, then you'll see the eyes moving in a characteristic pattern. And then your ear, nose, and throat doctor may also inject warm water or cold air or warm air into the ears. Exactly.
And I hit the ground.
Those can be miserable because they're injecting water or air into your ear to get fluid moving in the ear via convection current. So basically the cold or the warmth causes the fluid in your ear to move, and that allows them to test the integrity of the inner ear apparatus. And after all that testing is done,
that should take it down from the 18 things that I just said. That starts out with about 18 things. That should bring it down to one or two.
Exactly. As well as a neurological exam, they should do some component of that. And if there are no signs of a tumor or stroke,
I was going to say, and if the neurological exam picks up signs of possible tumors or something, then
they refer for an MRI. Yeah. Exactly. So that's the flow.
And our patients have been through that by the time they get here. A lot of patients, this is what you should be going through. And the reason I asked Dr. Gates to do that is because a lot of patients don't go through that.
Right.
A lot of patients get not that background, not that extensive workup, and that's the minimum workup you should have if, as you're going through this, they've already given you some medication, it's not working, so on and so forth. That workup will and should give the practitioners a pretty specific idea of what's going on. Now, patients come to us, they either don't have any idea or they have been diagnosed with vestibular neuritis or Meniere's disease. That's still there and still not responding to anything.
Right, we see the chronic cases. And what's now being shown about these two conditions is that it's primarily autoimmune in origin, or viral triggered or allergic.
I got to tell you, when we started doing this, I didn't even know what autoimmune was. I mean, I knew autoimmune was like multiple sclerosis and lupus and these types of things. But if you watched any of our 70 hours or so of stuff that we have online, or however many hours and 70 subjects or whatever it is, we have a lot online. We keep talking about autoimmune. This one was a little surprise to me, but then it wasn't, because in retrospect, we've been treating people for fibromyalgia and chronic fatigue, and it seemed like their Meniere's was getting better.
Exactly.
So autoimmune, why don't you go into that?
And I mentioned it in another broadcast, but I'll bring it back up. It was really interesting because when I started into clinical practice in 2009, at that time they thought a very low subset of the Meniere's population had autoimmune problems, like 8%, then went to 70%, then somebody said 20-some odd percent. And now they're saying immune and allergic mechanisms are primarily responsible for Meniere's disease. And what happens with Meniere's is that the inner ear, basically the balance portion of the inner ear that senses motion of the head, as well as the hearing part of the inner ear, starts to swell. And it swells because the drain for the fluid in your inner ear isn't draining appropriately. And some people call it endolymphatic hydrops. You don't need to know that. But basically that swelling motion of the inner ear will cause the inner ear to fire off too much, so you get the ringing and you get the vertigo, and then it shrinks back down, and then you get a lack of those functions. And because the brain is getting really confusing signals, that can be really hard to compensate for. So basically, they're seeing that that swelling is happening because the drain may be getting clogged by immune chemicals. Possibly.
And a lot of patients, I talk to them, we live in the world of autoimmune, you and I, and a lot of patients come in and I start talking about autoimmune. A lot of people don't know what that means.
Exactly. So autoimmune means that the person's immune system is killing them in some way, shape, or form. We have an immune system to get rid of viruses, bacteria, funguses, parasites, to kill those things, clear them out of the system, remember that they were there so that they never get in again. That's what our immune system is designed to do. It's not designed to kill us at a high level. And when it starts, when it starts doing that, we get problems. And unfortunately, it's becoming an increasingly prevalent problem. We talk about it every week. 1 to 12 to 1 in 6 people have an autoimmune disease.
Yeah, and we're seeing it. I mean, just about every fibromyalgia patient that's ever walked in here has had, probably, I think I would be accurate if I said multiple autoimmune attacks. Your immune system can attack almost virtually any tissue in the body. It seems to have an affinity for certain tissues like the thyroid, the gut, which is known as celiac, the thyroid, which is known as Hashimoto's, the cerebellum that Dr. Gates talks about. We see immune attacks against the cerebellum all the time.
Very frequent.
Meniere's, it can attack your joints, rheumatoid arthritis, it can attack the outside sheaths of your nerves. You're more familiar with that, multiple sclerosis. But these subtle, more subtle autoimmunities, and for those of you who have Meniere's, maybe the word subtle isn't such a good word, but it's not as embraced or not as well known a vehicle yet out there in either the medical or alternative community as it will become over a period of time.
Right.
And because it just takes time for it to break through that medical physical therapy model. I mean, it could be 5, 10, 15 years before this is completely embraced in that world. Our patients don't have that long to wait. So autoimmune, if you didn't understand that, you need to kind of look it up and review it a little bit, because if you have Meniere's, trust me, you have an autoimmune attack going on probably somewhere else in your system also.
And there are a lot of articles that are discussing that. They first started seeing that Meniere's patients may have other autoimmune conditions that kind of led to the exploration of this issue. And the hard part about inner ear autoimmune disease, and I'm using that as an umbrella, that is technically a diagnosis, but as an umbrella, basically, it's hard to get to the inner ear to test what the immune system is doing. Lots of times these studies are done on people who ended up dying by accident, who have these conditions. They go and they actually do an autopsy of the vestibular nerve, or the apparatus, or the ganglion, which is where the nerve goes in the brainstem. but also we don't have the laboratory testing yet to really quantify what is going on with all of these autoimmune processes in the inner ear. We have great tests for autoimmune thyroid disease. We have great tests for autoimmune cerebellar disease. We don't have great tests for autoimmune inner ear disease. And so...
But even those tests are inconsistent.
And they're inconsistent.
So the point that Dr. Gates made, we were talking about this before we went on, and it's a point I make to a lot of patients, is people want to know why we have a 17-page history we give them and why we do an hour-and-a-half exam. Because you have to, in most of these autoimmune cases, there is really, if the testing is there, it's inconsistent and thus frequently unreliable if you only take one test. And so the patient's saying, well, my test is normal, and, but I have all this, and then what are you going to treat it for? And we're like, we're going to treat you for what the history and the exam shows, which Dr. Gates refers to correctly as a clinical diagnosis. So a lot of times, you don't get a clinical diagnosis either because the history isn't done or the exam isn't done outside of the standard examinations that really aren't there for Meniere's, okay? And or the person kind of has a strong inkling you have Meniere's, but may not want to treat because they're concerned with malpractice and things of that nature because it's very black and white now. Why do you treat them for Meniere's when the test didn't say anything?
Right.
Well, there's not much of a definitive test for Meniere's. And I'm just telling you some of the things our patients have run into. I'm not trying to knock anybody. I'm just telling you the state of where it is relative to Meniere's. And again, to repeat, like Dr. Gates said, a lot of Meniere's comes in. They've had it for years. They've given up on it, but they come in now with fibromyalgia, or they come in with something else. And fibromyalgia usually has multiple autoimmune attacks. One of them can be the cerebellum, one of them can be the gut, one of them can be the thyroid. One of them can be your inner ear.
Yeah. And then relative to vestibular neuritis, what we're now seeing is that it's an autoimmune neuropathy of one of your vestibular nerves. So there are two nerves that go to the balance center.
There's a lot of things you're going to have to translate
exactly.
right there.
No. So there's, in your balance center, it's called the vestibular system. There are two nerves that come out of there, basically, and there's a one that's low and a one that's high. The one that's low is called inferior. The one that's up at the top is called the superior vestibular nerve. And the superior nerve they're now seeing is the one that's primarily affected in vestibular neuritis. And they went in, they saw all these CD4 and CD8 cells, which are immune cells. I pointed to Dr. Rutherford because we used to run these tests on our patients to look at autoimmune quotients.
They were pretty helpful.
They were helpful. And this came from an immunology journal because a lot of people are having a hard time understanding the balance of the immune system. But basically what they see is that the immune system is way out of balance in that part of the nerve is dying. And again, as I mentioned, lots of times vestibular neuritis is preceded by a viral infection. And they're thinking that the immune system is trying to kill the virus, and in an effort to do so, overreacts and starts killing the nerve. We have attached a number of journal articles to today's broadcast.
I was just going to say, when Dr. Gates says they, the vast majority of what we do is based on research that's out there that's either not being used because it's not resulting in a surgical procedure or a drug procedure, or in this particular case, without knocking anybody, or physical therapy procedures. There's some general procedures out there that are moderately ineffective, but they're still being tried, and so we
just say for the patients we see.
Yeah.
For the patients we see.
Yeah, for the patients we see. Exactly. Because obviously it didn't work for them. Yeah. But Dr. Gates was about to say that he has attached.
Several research articles. One is fantastic. I can't remember if it's the first or the third article, but it's a beautiful description of vestibular neuritis from, again, an immunology journal from, again, like a couple months ago, where they were talking about how vestibular neuritis patients so commonly have been treated with antiviral medications. And though I want to argue with that, not that we prescribe medications, but from a conceptual standpoint, we want to argue with that. But they're now seeing that the viral medications really don't do a lot, but corticosteroids.
I was just going to say, so what I hear is, I went on steroids for my other autoimmune problem, or for and
I got a lot better.
I got a lot better because steroids address
that exact
the immune system.
They calm down the immune system, and now for you Meniere's patients out there talking about medical treatments, they're now injecting steroids through the eardrum if you're familiar with
Okay.
the
I
eardrum.
haven't heard that yet.
Yeah, brand new stuff. They're injecting steroid through the eardrum, and that's seeming to calm down the inflammation in the ear. But even more interesting, because steroids can imbalance salt levels, that it's throwing off the salt levels in the inner ear as well.
Okay.
Yeah, so it's kind of a catch-22 check.
Well, and that's the thing about, that's the thing that I embraced functional medicine and functional neurology. I was actually taking some functional neurology courses before Dr. Gates got here. The physiology, the biochemistry of the body is so mind-numbingly complex. And frankly, we may never really understand it all. I mean, that's the reality of it. And so to interject any type of a substance in there, you're going to get some sort of reaction. That drink of water that he just took created 136 different biochemical reactions in the body. How about stress? The stress affect these folks? Affects Meniere's patients dramatically. And I used to have this poster that was ginormous on the wall. And I had this person who was standing there walking along real happy, and then it showed when they were a little stressed, and then they were stressed, and they were more stressed. And there were hundreds of chemical pathways that were affected by that. So what we're talking about is really addressing more of the main large biochemical pathways and the autoimmune process, the immune system, more of the larger systems involved, and we seem to get a better response without a lot of side effects, really any side effects in essence. So.
Yeah, especially now,
and not hurting anything else, not interfering with sodium balance.
Right. And we talked about the physical therapy modalities. We're going to get into that. Some of they're termed oculomotor exercises. Basically, they entail a person with a inner ear problem looking at an object and shaking their head or shaking an object while their head is still. And in our experience, the patients who have come to us who haven't done well with those things are very, very sensitive. It might possibly be due to the fact that the immune system is not only affecting the inner ear, but also the cerebellum, which is the balance center. And so you really have to be careful how much, at least in our experience, how much you give patients with inner ear disorders in terms of eye exercises and things like that, because you can equally do as much harm as you can. Good. And in fact, it's ways to do more harm than it is to do good.
Yeah, one of the things that we evaluate on our first visit is the patient's threshold, their metabolic, what we call their metabolic threshold, and it's what Dr. Gates just described. And with our first evaluation, we'll treat the patient. We will treat the neurological issue relative to Meniere's. And Dr. Gates is very careful to use very, very, very minimal stimulation or very minimal exercises, because if you do exacerbate it, you're damaging neurons. And so if you're in there doing this, and again, I'm not criticizing this, I'm just saying if you're doing this and you've been exposed to this for Meniere's or vestibular neuritis or whatever, and you're feeling worse, and you're told to keep going, we're just telling you don't. Okay. You probably have an autoimmune problem. It's probably attacking your cerebellum, and your practitioner may not be aware of that. This is very new stuff. We're up on all this new stuff because of him, because this is what he does at night. He doesn't do anything else. He just does that. He drinks coffee. He listens to music in his ears, and he researches. And so,
I'll give you the name of the coffee shop.
I'll give you the name of the
coffee
shop. Here in Reno, Nevada. You're in Reno, Nevada. And I don't think we have anybody in Reno, Nevada doing those cortisone injections into the ear.
Not I know. Well, that's another thing I didn't talk about in terms of medical treatment. So for a lot of Meniere's patients, if they've had it for a long time and it's disabling, they will basically go into a treatment where they either cut the vestibular nerve, which is the nerve coming from the balance mechanism, or they'll go in and they'll just scrape out the whole inner ear mechanism as well. That can be good. There are some reports that it can be effective, and there are other reports where it's ineffective. And the problem is with any surgery, once you cut something out, there's really no going back. So it may work, but it also really may not work. And we had a case this year. Let's just say the cases that we properly selected who had Meniere's that came into our program, we don't take everybody, so we're not saying we have a cure for everybody. But the ones we selected,
we don't take everybody because after the evaluation, if it's obvious that it's too far gone, there's too many things involved, or maybe the patient's not willing to do what's necessary to get better, then this probably isn't a good place for them to spend their hard-earned dollars.
Yeah. And we had done very We had great results with Meniere's patients.
Yeah.
We've worked with, let's just say it that way.
Just,
And then we had this one gal who did really well with her treatment, and then she started taking a variety of herbs at the beginning of this year, and her Meniere, and herbs can be very powerful at stimulating the immune system. We commonly caution our patients on taking them without being in a controlled environment. Her Meniere's completely got flared up. She was having vertigo on and off for 2-hour periods for 3 weeks out of the month. Can you imagine how awful that must have been? So she went down to an ear, nose, and throat surgeon in Sacramento who does these procedures where they go and they cut out basically the balanced portion of the inner ear, and he recommended that she have it done. She came back to us and said, is there anything else we can do? And we referred her to a medical practitioner we work with who did put her on steroids, and she's been good ever since.
But to go back on that history now, we tell people when we're done, by the time we're done with this, we give people a program and say, we don't want to see you again unless something happens. But if you do this program and don't deviate from it, and don't listen to Dr. Sanjay Gupta, and don't listen to Dr. Oz, I'm sorry, I'm not being controversial, I'm just telling you because they have pearls every day. They have to put content out. And so people are going like, ooh, maybe this will help. No, it won't. We just figured this out. This is what you need to do. Just keep doing it and you'll stay better. The confusion on herbs that I see every day when I talk in these consults is people think herbs good, okay?
Right.
Autoimmune patients have an immune system that is already hyperactive. For lack of a better term, it's already looking for tissues to attack and damage, okay? So do you want to boost your immune system if you have an autoimmune problem? No. Steroids don't boost immune systems. They calm it down and, or in my term, crush it so that it can't flare up and attack anything in an MS patient or a rheumatoid arthritis patient, so on and so forth. So you want to be careful if you have Meniere's. You don't want to be looking at herbs and botanicals and stuff. What we want in autoimmune cases, we want to calm the immune system down or balance it or both. So that's just a little tag on to that. Lady created a situation by going and taking all these herbs that she heard from someone else would be good, and then ended up in surgery. And now she's going to be on steroids.
Right, and actually she's off now, and she's doing well.
Okay.
So you know, that other medical practitioner we referred her to kind of saved the day, but she probably wouldn't have been in that precarious situation if she hadn't started taking the herbs in our opinion.
Right.
So in terms of medical treatments,
there you go. I was
otherwise,
just going to say, so kind of like encapsulate that. You have you haven't really talked about the medications,
right?
Which seems to be the most common, and then you've talked about the surgeries. You kind of touched a little bit on the physical therapy, but maybe do that a little bit more organized.
You got it.
Fashion.
Absolutely. So basically, let's say you have vestibular neuritis. All of a sudden, you're sick. The next thing you know, you have vertigo lasting days on end, where the room is spinning around you. You're throwing up. You don't have any ringing in your ear. You go to the emergency room. Likely at that point, they need to put you on corticosteroids. Likely they are going to. Basically, I say they need to because the current evidence shows that for those patients who have vestibular neuritis, if they get on corticosteroids right away, lots of times the duration of the illness and the severity of the illness is shortened. Does that make sense?
Yeah.
Okay, perfect. So, not to you, but to the layout.
No, I know what you mean.
So, anyways, corticosteroids is the primary intervention. Some doctors will still use antivirals. Can't argue with that. And then after that, the vestibular neuritis patient is recommended to exercise. As soon as they stop vomiting, for them to get out and start moving. The reason why is that causes the cerebellum, the balance center, to start compensating for the loss of signals from that inner ear. They may also be given some anti-vertiginous drugs like meclizine. Many of you have heard of that.
Seems to be the most common one.
Antiemetic drugs, which basically cause you not to vomit, like Phenergan, like Reglan, and you may be given something like a Xanax just to calm you down while you're having the vertigo. And the Xanax actually calms down the inputs from the inner ear too, so it just helps your brain to balance out in the acute period. For Meniere's disease, the typical treatment is a little different. Commonly, the Meniere's patient is going to be recommended to go on a low-salt diet because the inner ear fluid is regulated via salt mechanism. So basically, the more salt in your system, the more your inner ear is going to swell. And if it's already swelling too much, that's a bad thing. So they put you on a low salt diet. They may put you on a blood pressure medication termed hydrochlorothiazide, which is a diuretic, and it just causes you to pee salt out, or to urinate your salt out of your body. And then they'll put you on basically the same medications, antiemetic medications, antivertiginous medications, Valium, things like that, to help just calm your brain down during the acute attacks. Those are really the standard medical treatments. Now, as we discussed, there are more novel treatments being used relative to possibly injecting corticosteroids into the inner ear of Meniere's patients. And then there are, of course, the vestibular ablation surgeries where they go and cut the vestibular nerve and they cut out the inner ear.
Yeah. Newer treatments, they're still kind of new, but they're being used, and time will tell on those. So that's Meniere's and that's vestibular neuritis. Now, there are other ways to go about this, particularly given the fact that Meniere's is an autoimmune problem. So our techniques have been developed along those lines in combination with Dr. Gates's background in brain function and brain rehabilitation. So I think that people watching this probably might be interested in knowing what that is.
We look at the gut heavily because that's where 70-80% of the immune system is. And I wonder who figured this out. Who started working with the gut? Was it naturopaths? Was it Datis? I mean, who really came onto this? It's really interesting. Datis Karazian, you wrote a great book. Why do I have thyroid symptoms when my lab tests are normal?
And why isn't my brain working? I think is the other one. I think it's hard to say. I've read things from back in the 80s.
Okay.
On gut function. A local homeopath around here was working with the gut and gluten. He didn't call it gluten at the time. I don't think they knew it was gluten. He was working with wheat products. He even wrote a book on it, I think. Dr. Dave Edwards. Dave, I know you're not watching, but we'll give you a little boost there. Dr. Dave Edwards, a local, one of the first to break the mold with homeopathy and being, he's an MD. Is actually an ex-cardiovascular researcher who got into this, and he was the first one I saw. Now, and then people have been doing cleanses for thousands of years. They've been doing liver cleanses, and they've been doing fasting, which all of these things positively affected the gut and the immune system and inflammation and so on and so forth. It feels like Dr. Datis Karazian out of San Diego was the one who just really almost more or less forced the issue. Prior to that, I don't remember seeing entire seminars with what he used to call a 4R program. I don't even remember what the R's are for. It was like remove, restore, repair, replenish, something like that. That was the first time I saw an organized approach to it. But I think Dr. Gates says that because when we say to somebody here, we're going to start with your gut, they're kind of like, well, my problem's in the ear.
And now the literature is overflowing relative to how the gastrointestinal tract and how the American diet basically feeds certain populations of bad bacteria. These certain populations of bad bacteria are associated with certain autoimmune diseases, and not all of them have been characterized yet. We feel that Dr. Vasquez out of Oregon has done a nice job in his book, Integrated Rheumatology, and talking about certain species of bacteria relative to certain autoimmune diseases. And basically, the rubber meets the road at the GI tract, because that's where most of your immune system is, because that's where you're most likely to die, because you're going to eat something you shouldn't have, or that was old and crusty and has a lot of bacteria on it. So basically what we're seeing, though, is that the American diet is feeding certain types of bacteria, and these bacteria can start to bloom, and parts of them can break off and go into the bloodstream. They can create inflammation, such that the barrier function of the gastrointestinal tract, which is there to prevent big molecules from leaking into your bloodstream, suddenly that can start to happen. That's referred to as intestinal hyperpermeability, or more commonly as like leaky gut syndrome. And then that can initiate the immune system to attack those dietary antigens, as they're termed, so there's just food molecules. And then that can cause the immune system to get overreactive and then therefore attack Lord knows what. in a lot of circumstances. We have seen with the Meniere's patients who lots of times have other autoimmune problems to do really well in calming down their systemic inflammation. One thing I didn't talk about, I attached an article today. It was unbelievable. They looked at something close to 100 patients with Meniere's, or it was vestibular neuritis, and they saw that all of them had high homocysteine levels.
High inflammation.
High inflammation levels.
In theory, in the brain.
Right. It's really throughout the body.
Homocysteine is an inflammatory marker, inflammatory blood marker that indicates high inflammation in the body, and currently the thinking is that it's more specific. It's general, but has some specificity to the brain, which is where your vestibular mechanism.
Exactly. And so, very, very interesting study, but it's just a connection between inflammation, autoimmune problems create inflammation.
And then just take a step back there, back to the gut, okay? As Dr. Gates said, 70% of our immune system is in the gut. So, and what is Dr. Gates describing, okay? He's describing a more, if you will, a little bit more labor-intensive approach to calming your immune system down. Now we're back to calming your immune system down, which is what steroids do, okay? So you have the choice. You can do steroids, often over a lifetime or a long period of time. This is the same approach that would be taken for Meniere's. Is the same approach for those of you who have Meniere's and maybe have fibromyalgia, or maybe you have Meniere's and peripheral neuropathy, or maybe you have Meniere's and celiac. I'm going to tell you, they're all autoimmune problems. In our world, it's an autoimmune problem. You attack the immune system no matter what the name of the immune problem is, whether it's rheumatoid arthritis, or lupus, or multiple sclerosis, or Hashimoto's. And that's the other thing. If you will take the approach that Dr. Gates is delineating here, but you might have also in combination with that, let's say an autoimmune attack on your thyroid, and if you are calming the immune system down, but your thyroid is also, let's say, a little bit beyond that, it may need some help. You may need to actually calm the immune system down and then deal with some of the other organs that are being affected to get the Meniere's under control.
Right, exactly. And lots of times there can be viral infections.
A little complex.
Yes, in the inner ear, but there can be viral
infections
infections throughout other parts of the body. There can be what are termed Pseudobacteria that live in our cells that can basically elicit the immune system to be imbalanced. So there are a variety of things here that start to interplay off each other. But we always start with the gut because we see that's where the biggest changes can be made. If a change isn't made, then that's where we start looking at other protocols for other types of organisms. And also we work with other medical practitioners. Yeah. And some patients need gentle immune calming medications in our experience that have worked very well for these types of problems. So that is the natural treatment. And then we couple that with neurologic rehabilitation, because if you have an inner ear lesion, let's say you have Meniere's and your inner ear function is going up and down, or if you have vestibular neuritis and basically it's just squashed, if your brain is not able to compensate, think of your car being out of alignment. If you can't get your car back into alignment because your cerebellum isn't compensating, and as a result of that, you're always going to be dizzy, you're going to feel off, you're going to continue to have vertigo. And keep in mind too, the cerebellum has to take in a multitude of signals. You know, we know when we're in the first grade as the senses, you know, sight, hearing, whatever. But basically the cerebellum has to take in hearing information, information for where our head is relative to our neck, information from our neck telling us where our neck is relative, or our head is relative to our neck. We have to take in information from our feet, and we take in visual information. So the cerebellum has to take all those inputs and say, oh, here's where I am. But then if you lose one of your systems, think of an engine going out on the plane, can the plane still fly, or is the plane going to go down? And that's analogous to an inner ear nerve lesion. If the cerebellum is good, you can compensate. If the cerebellum is not as healthy in its function, then you're going to have a hard time compensating. What we do is we do specific eye exercises to go into the part of the cerebellum encoding where that nerve sends its signals to try and bring that part of the cerebellum back so the person can compensate in their daily activities.
And people think the exercises look silly.
And they look simple.
In the beginning, people, you can see out there, we have a brain rehab gym, as what we call it, our brain rehab gym. You can see people kind of like, you know, doing this. And then about halfway through the program, when they're feeling a lot better, I go, I must admit, I really didn't think that this was going to help me.
Right.
but they're very powerful.
And now we...
If you are prescribed the right exercise based on the correct history and based on a very precise neurological exam that identifies which part of that cerebellum needs to be affected to strengthen it and for it to be able to do its job. And cerebellum, by the way, means little brain. And it gets that name from the fact that it has to do so much work and coordinate all brain function. And you'll be hearing a lot more about it in the future, because I'm starting to hear about physical therapists now and other doctors going, oh, it's this. I even heard on Dr. Sanjay Gupta, and he was wrong on what he said, so don't always listen to him.
And it's very analogous. Some of the analogies I use with patients is that when you're giving certain routines, maybe by a physical therapist, and let's say in the event this didn't work for you, where you're shaking the pen back and forth, you're turning your head like this. If that doesn't work for you, think of it as going to the gym and putting 400 pounds on the bench press. And if you haven't worked out, maybe you can't do that, and you might tear a muscle doing that. And so they're trying to just get your brain to compensate, but if your cerebellum is weak and it can't compensate, you have to slow the process down and give the cerebellum what it can handle. That may be as much as 2 reps of this, and then you stop. Or maybe 1 rep of that, depending on a detailed neurological examination, as well as we do a detailed video nystagmography examination, where we really look to see how the cerebellum is functioning, its ability to do what it should do or can't do. Also keep in mind the vestibular system, which is the inner ear, is like a gyroscope on a plane. And if you lose 2/3 of your ability to sense, or 1/3 of your ability to sense a certain plane of motion, then your cerebellum has a blind spot. I hope that makes sense. So if you can't sense motion in this plane, then your cerebellum loses orientation of where that is, and you may just have to rehabilitate that plane of motion.
That's probably maybe a little bit beyond.
So,
but,
all right, well.
But one thing I would go back to and then wrap it up is when Dr. Gates went like this, what he was showing you was this can be very powerful. One of our mantras for all autoimmune patients in here is that less is more. That goes for exercises, that goes for herbs, and it's another one of those counterintuitive things that these new procedures run into when we're trying to work with patients, because patients' brains are more is better, more exercise, stronger exercise, harder exercise. Not with these cases. Less is much more effective. And that is a lot of data, I think, that we just covered. But the idea, and then we kind of toyed with this, the idea was to try to present all of the different aspects that we run into relative to vestibular neuritis and Meniere's disease, knowing that in our experience, these are the things that people have run into, going and having this done and having shots in their ear and just everything. So I hope we didn't overwhelm you. The idea was for us to make sure that whoever was watching this, we touched at least upon something that they had experienced. But to let you know that it's really about the immune system. In our case, the immune system is the alternative, if you will, or the natural treatment, or whatever you want to call it, is really about that. As Dr. Gates stated, 70% of your immune system is in your gut. And I might add, virtually all the chemistry that makes your brain work, minus maybe a little bit of other dopamine and stuff that's made up here, is made in your gut, pretty much. And so when the issue was forced that the gut was where we were going to start, things started happening. They started happening a lot quicker. That can calm a lot of things down. There can be other things that you can address once the gut is calmed down, but I don't think you can begin to diagnose an autoimmune patient until you get the gut being, by the way, small intestines, large intestines, pancreas, liver, gallbladder, the works in there, and not kidneys, not particularly, but those structures, until they're kind of calmed down in the autoimmune patient, you really can't go anywhere else. It's just too complicated to try to figure out. So that's the general overview, and so we start with the gut, calm down the immune system, and then the brain. that Dr. Gates is talking about needs proper fuel for it to respond. Dr. Gates likes to use the gym analogies. You don't be going to the gym and building up to that 400-pound bench press or squat while you're at home eating the wrong things, drinking the wrong things, being stressed out of your mind, sleeping 3 hours a night. So all of that has to be corrected for both your immune system to calm down and for these exercises to be maximally effective so that you can use more and more stimulation. So that's kind of the generality. It's a little bit more labor intensive, but it's a tool that you can take with you when you're done. And unlike the lady who decided to go and take herbs that we told her not to take, if you just keep doing it, not only will you stay better, but usually over a period of years, you'll continue to improve, usually long after we're done with the patient. So that is vestibular neuritis and Meniere's disease in probably as comprehensive a form as you will ever have presented to you in a lay lecture if you have decided to stay and listen through this whole thing. Is there anything else that you think you'd like to share? All right, so I hope that was very helpful for those of you who have that. If we haven't covered anything, if you have specific questions, please feel free to call us. Well, don't call us. Please feel free to
contact us at powerhealthtalk.com or
email us
to our Facebook page, Power Health.
And Dr. Gates will answer your questions because I am not a computer guy in effect. And so thanks for watching, and we will see you next time.
Yeah.